Poonam, let me know when to start. I think in another 1 minute we can start. ठीक है सुनील, don't worry, I'm there on this. Join the computer.
Manisha, a request. Just tell them if it crosses 100, they can join to YouTube link. Just remind them.
Messages to everybody on personal, so they will join on YouTube link. That is also being shared. Okay, I think we can start. Yeah.
Your voice is echoing.
Is it okay now?
Yeah.
Is it okay now?
Yeah, now it's okay.
Let's move on somewhere else. Good evening, everybody. 2 months ago, we had a webinar on nephro and uro anesthesia, which was very well received by everybody. So we decided to do a second part of it. And this time we have very, very interesting cases, which will be of interest to all anesthesiologists who are working in the private sector as well as the corporate sector. We have included robotic surgery also this time, because many of us who work in the private sector do not have access to robots, but they're slowly entering our routines also. So we thought we would get a little sneak through Jupiter Hospital into robotic surgery. Before I start, I would like to, I have a few announcements to make. First of all, I would like to thank the entire team of Thane ISA and Thane Anesthesia Society for winning the award at the Karad CME, which was held recently. So we got the second prize in public awareness, and I'm thankful to everybody for that. Secondly, World Anesthesia Day is coming up on 16th of October, and Dr. Parna is planning something for that. She will let us know duly. The next webinar that we are having will be on 17th of October, which is again on a very hatke topic, which is not given its due, I feel. That is on ophthalmology and anesthesia. On the same day, we will also be releasing our e-bulletin, Samvedna, Let's Talk. The theme we have kept as which is the theme of WFSA this year, that is workforce well-being. So I request all our members to send in their articles, photographs, pictures, stories, poems, etc. to Dr. Vaishali Vavikar as early as possible. The next few months, we will be having a volley of conferences, and I request everybody to register for them. The first one will be MassCon on 19th and 20th of October at Nehru Center, Worli. Team MassCon has come with an excellent scientific program. Please do register for that. This will be followed by the ISA national elections, which are from 1st to 5th of November. So whoever has not updated their details in the website, please do that as soon as possible. The next conference is again in Amchi, Mumbai. That is the TechOn from 15th to 17th of November, which is very close to Thane and Chembur. So do register for that as well. This is followed by ISICon Patna on 20th and 24th of November. So those who are planning a trip to Patna can also combine it with Gaya and Bodh Gaya and have a nice education and a pilgrimage as well. And we will be rounding off the year with the ISIS-sponsored National CME in our own city, Thane, which is planned for 15th of December, the details of which will be shared shortly. So today, let me welcome all of you for this lovely webinar. Our chairperson for today is Dr. Vivek Birla, who needs no introduction. He's a neurosurgeon in Thane with over 30 years of practice and has a special interest in lithotripsy, PCNL, and other surgeries. And the moderator for today is Dr. Sneha Vaswani, who's one of the strong pillars of Department of Anesthesia of Jupiter Hospital, and she has a very great interest in cardiac surgery and organ transplant. Our MMC observer for today is Dr. Rochana Dikshit, who is from DY Patil, Associate Professor in the Department of Anesthesiology. So I welcome all of you for this very interactive session of nephro and uro anesthesia. And I hand over to Dr. Sneha Vaswani to start the scientific program. Thank you. Another thing, please don't write your names in the chat box. We have already registered you all on the Google form. So no, please do not type anything in the chat box. Only relevant questions and comments can be typed. Thank you, everybody. Sneha, over to you.
Thank you, Manisha. I hereby thank Thane ISA and all the participants. The first talk, there's a slight change in the talk. First talk will be by Dr. Tushar Dedia. He's been working as a private practitioner as an anesthesiologist for the past 33 years. He will be presenting a case of post-renal transplant. This patient has come up for an incisional hernia repair, and he will let us know what all, how did he conduct this case. Welcome, Dr. Tushar Dedia.
Thank you very much. Let us start this seminar. Just wait, let me share the screen. Thank you, ISA, for inviting me to the talk. My speech today has been divided into two different parts. Initially, first part I am going to speak on general things which we do in after renal patient, general anesthesia consideration. So initially I'm going to speak, and afterward I'm going to speak about what I did actually in one of the real case scenario. So this is a case of incisional hernia repair after renal transplant patient. General consideration, these patients after transplant have better survival rate thanks to better immunosuppressive regime, good surgical skill, and very good ICU after surgery care. Kidney function is almost within normal limit in all patients, but glomerular filtration rate usually reduces by 1.4 to 2.5 ml per minute per year. Then what are the pre-anesthetic consideration in this patient? The identification complication and their anesthetic implication, the immunosuppressive agent toxicity, rejection of the renal system, and infection. The concerns on transplant patient is that altered function, physiology related to organ, the altered function due to immunosuppression, which can be malignancy, infection, toxicity, potential interaction with another medications, intention organ rejection. Then second is glomerular filtration rate. Is usually reduced even if creatinine is within normal limit. Second most important thing is electrolyte abnormality. Then another is altered drug metabolism. The common problem after the transplant includes increased risk of CAD, coronary artery disease, hypertension, diabetes. The immunosuppression leads to the de novo hyperlipidemia. CVS diseases are the most common cause of death in these patients. The electrolyte abnormality and altered drug metabolism, as I said already earlier. The other complications include very early complications, cardiomyopathy, then acute graft versus host disease, then can be hemorrhagic cystitis, interstitial pneumonitis, veno-occlusive disease. Very late can be the chronic graft versus host disease, leukoencephalopathy, malignancy, hypothyroid, cataract, COPD. The other the common immunosuppressive drugs which are used in these patients are cyclosporin, tacrolimus, steroids, methylprednisolone, then azathioprine, mycophenolate, mofetil. The anesthetic consideration includes the main goal is to maintain renal perfusion prevent harm to already compromised renal function by avoiding hypoxia, hypovolemia, and hypotension. Pre-op evaluation considers history, the cause of renal failure earlier, and the duration of the management. Needs for the dialysis after surgery should be explained to the patient and relative. That is SOS if required. And inquire with nephrologist about the fluid restriction, if any, and urine output. You can and the history of comorbidities like diabetes, hypertension, ischemic heart disease. Then inquire about exercise tolerance, anemia, left ventricle failure, the electrolyte disturbance, and nephrology opinion is last but not the least. Then on examination, we have to find examination BP in standing and sitting position. That is to rule out autonomic neuropathy leading to orthostatic hypertension. Check for hemic murmur, uremic pericarditis. Then ankle and sacral edema. Look for the signs of early rejection like azotemia, proteinuria, hypertension. Rejection is the main cause of late mortality, and any surgery during the period of rejection have very high morbidity and mortality. Look for other sign of rejection like poor appetite, fatigue, fatigue and irritability. In this patient, if rejection signs are visible, do not consider doing elective surgery. But in case of emergency, after consulting the patient and relatives, we can do the same with considering the risk-benefit ratio. You have to maintain adequate level of immunosuppressive agent in consultation with the nephrologist. The main investigation, which we do is CBC coagulation profile, renal function test, ECG, echo. In ECG, look for arrhythmias, LVH, any rhythm blocks. X-ray test, do not diffusion, megaly. Then arterial blood gases if available, and liver function test. Mainly, pre-op optimization, mainly we do as per the nephrologist advice. Continue immunosuppressive drug and antihypertensive and other arrhythmia drugs. We have to optimize serum potassium levels. Then as far as possible, we have to avoid blood transfusion to avoid sensitization of the transplantation. Then avoid metoclopramide and H2 antagonists for gastric reflux because they can interact with the immunosuppressive agents. Important point to note that this surgery should be done with very strict aseptic precaution as you do with the TKR or any ophthalmic surgery. And also ideally should be done in center with in-house dialysis center and nephrologists available. General anesthetic consideration in this patient, adequate with pre-oxygenation, propofol slowly so as to avoid hypertension, succinylcholine, only if serum potassium below 5.5, or use atracurium. Atra is advisable because of Hoffman illumination, or you can use vecuronium or rocuronium, but you have to remember that repeated doses requirement is reduced. Then maintain with oxygen nitrous and isofuran. Isofuran is the inhalation of choice, is only 0.2 undergoes metabolism and produces very low levels of fluoride ions. Fentanyl had been used but to avoid infusion. If we are using azathioprine as a immunosuppressive agent, then we have to watch for non-depolarizing muscle relaxant like atracurium as they are required in large doses. We should avoid hyperventilation and absolutely avoid NSAID. Regional anesthesia is very good if the operation profile is within normal limits. We have to think of thrombocytopenia if the patient also have a prime immunosuppression. Specific anesthesia consideration, we have to choose the drug independent of the renal system for excretion. The intraoperative monitoring BP and blood glucose level, ETCO2, ECG is like routine. CVP if patient is undergoing supramajor surgery where we are expecting very large fluid shift or blood loss, maintain urine output at 0.5 to 1 ml per kg per hour. And if is low, you have to you can give mannitol or Lasix if required. Then avoid starch or volumen or like this type of fluid which can accumulate in the body and can impair the renal function. Gelatin is safe to use. Ringer lactate can be used if serum potassium is within normal limit. Maintain normothermia by attaching warmer. Then as far as possible, avoid blood transfusion as stated earlier because it can increase the hematocrit level, which again reduces the renal perfusion. We can use paracetamol as an analgesic interop. Reversal with neostigmine can be done. However, refibrillation can occur and proper recovery room monitoring is essential. Sugammadex is primarily excreted to renal system and it can lead to delayed excretion in some patients, leading to potential risk of neuromuscular block recurrence. So it is ideal to avoid the use of Sugammadex. Stop analgesia, paracetamol, epidural, wound infiltration, or love block. Now coming on to my actual case, it was the case of incisional hernia in 33-year-old male patient. Renal transplant was done 3 years back. Donor was patient's own mother. Complaint of mild pain and swelling at surgical incision site. Patient otherwise was symptomatic. History on examination, no fever, vomiting, pain or burning while passing urine, very good urine output. History of hypertension, no history of diabetes, no history of edema of feet or swelling, no history of lethargy or exhaustion. Pulse rate 72 per minute regular, blood pressure 140/84 in sleeping and 130/80 on making patient sit. So no orthostatic hypertension. Hypertension. Respiratory rate is 18 per minute, weight 62 kg. On investigation side, CBC hemoglobin 12, rest of the thing was normal. Serum create was 1.1, sugar fasting 120, PP 175, all BTCT, PT, INR, everything within normal limits. Urine normal, no proteinuria, electrolyte, potassium 4.7, ECG normal, X-ray chest was normal, 2D echo, LVA 45%. Current medication patient as an antihypertensive was on amlodipine and immunosuppressive agent triple drug regimen patient was on tacrolimus, mycophenolate mofetil and prednisolone. So on the day of surgery, very early morning with water, tacrolimus and mycophenolate mofetil was given by mouth and IV Apolline had 100 milligram was given as the induction. Surgery was done at 8 o'clock in the morning. And how I did it? It's done in well-equipped center with laminar flow OT and dialysis backup with nephrologists in the hospital. I did it under regional anesthesia, spinal epidural combined. Spinal at L34 level, I gave full 1 ampule 4 ml bupivacaine 0.5% heavy plus fentanyl 0.05 ml, that is 25 mics. Then epidural catheter at last a level above 16 gauge, but not given any medication through epidural. Intra monitoring ECG, SpO2 and NIBP, IV fluids, ringer and NS alternate total around 4 point required. BP was maintained between 100 to 120 systolic. Duration of surgery was 2.5 ghanta, 2.5 hours. Sedation, 75 bites of fentanyl that was remaining from earlier ampule plus 1 gram midazolam, oxygen, nasal cannula. Procedure was absolutely uneventful. Just before the surgery was over, paracetamol 1 gram IV given. And also the wound infiltration with bupivacaine 0.25%, 15 ml was done. After the surgery, anesthesia via continuous infusion pump on epidural catheter was given. Medicine used in epidural catheter is 50 ml ropivacaine 0.2% plus fentanyl 1 ampule 2 cc given at the rate of approximately 3 ml per hour, which we adjusted as per the pain response of patient. Epidural catheter removed after about 42 hours after surgery. Analgesia was intermittently given by paracetamol, and rest of the management was done by the surgeon and nephrologist. Patient had a completely uneventful post-op and eventually discharged on day 4. In short, I would tell that this was a complete team management effort between surgeon, nephrologist, and anesthetist. This coordination was extremely essential for better patient outcome. And, along with this, the proper infrastructure also matters. Thank you very much. This was my talk in short.
Thank you, Dr. Tushar. I think I've tried to cover up almost all the points.
Yes.
There are so far no questions in the chat box. Dr. Vivek Birla, if you're online, kindly give your expert opinion regarding the same.
Am I audible?
Yes.
Yes, sir.
Yeah. See, now that many solid organ transplant patients are going to live longer because of good immunosuppression, good surgery outcomes, they are likely to face some problem or the other. But from a surgeon point of view, it is extremely important to understand whether this patient really needs a surgery or not. I will tell you frankly, some of these.
Yes, we are not audible, Dr. Birla.
Dr. Birla, we cannot hear you.
Yeah, am I audible now?
Yeah.
Yes, yes.
Yeah. See, with a lot of solid organ transplants which are going on and with good immunosuppression, the longevity of these post-transplant patients is increasing. And they are likely to face some problem or the other, which may need surgery. But it is very vital for all of us to understand that whether the surgery is definitely needed or not. That is the first and foremost, because whatever the type of surgery we subject them to, there are likely to be some complications sometime or the other. And obviously, these are compromised patients who are on immunosuppressions, who have a high risk of infection, who have coagulopathy possibilities, they are may end up with rejections, and whatever said and done, the kidney transplant is a major surgery with which the person has to live his remaining life. So if something little bit also goes wrong in a surgery or anesthesia, he is going to lose that kidney forever. And he is going to be again on the waiting list for a long time for the transplant to happen again if he does not have relatives. And how many times he is going to land up with these surgeries? So it is very vital from a surgeon point of view that whether he really needs a surgical intervention. Why am I stressing is this? Some of these patients are directed from a general practitioner for a small inguinal hernia or a little swelling in the hernia side. It is a reducible hernia. They don't really need a surgery. Inguinal hernias many times, I'm not talking about incisional hernias, but in general hernias. Now, incisional hernia also is not very uncommon in a post-transplant patient because of muscle weakness, because of they are immunosuppressed, don't have a strain, they cannot do exercises. Sometimes the surgical incision is not closed properly in a hurried, it is closed by the urologist. So many reasons are there. But many of these incisional hernias don't need an intervention. So first and foremost, whether this person really needs an intervention, that surgeon has to decide, obviously, with a due consideration. That is the first part. Second part is obviously Dr. Tushar Reddy has covered most of the points. But most important is whether these kidneys would remain well perfused during the anesthesia. Obviously, the local or a regional anesthesia is preferred over general anesthesia in majority of the setups. But again, whether we are doing the proper medications, whether immunosuppressions is not halted in between, it is given properly, and anesthetic agents don't have a drug reaction with immunosuppressants. All these have to be taken into consideration to give a good outcome ultimately. So that's all. Thank you.
Thank you, Dr. Birla. That was very informative. And yes, the surgeon decides the surgery. There are one or two questions in the chat box. One question is, can sevoflurane be used? I think Dr. Tushar should be answering this.
Yeah, we use isoflurane because 0.2% of it only it is fluoride are produced. So isoflurane has a better advantage over sevoflurane. But if not available, you can use sevoflurane very low dose in low flow gases setup. But as far as possible, in the nephrology all books, they have said as far as possible use isoflurane.
Okay, the next question, I think someone has asked when was the epidural removed, but sir has already answered after 48 hours. Am I
Yes.
right, sir?
Yes. I already said.
And the third question in the chat box is isobaric segmental spinal anesthesia preferable? If epidural in C2, then why LA infiltration and IV paracetamol?
To reduce the doses of all medication. Combined approach, we have to reduce the doses of local lignocaine, everything. If we give only epidural, then the sometimes epidural analgesia doses of ropivacaine required may be high. Then there is that hypotension and all those things might come into the picture. So I want to avoid everything, small thing of all, which I did for that case. You can preferably do if the hemodynamic stability is there. You may not give wood infiltration, but if the multi-pronged approach would definitely help by reducing dose of every drug.
Okay. Thank you, Dr. Tushar. Thank you for a very informative talk.
Thank you.
Our
Neha,
second
can I
speaker.
say something?
Yeah, please.
Yeah. So we are getting a lot of patients who are post-renal transplant, post-liver transplant, post-cardiac transplant. And regarding inhalational agents, we are using all the inhalational agents, desflurane, sevoflurane, everything we are using, and it's absolutely fine for them. Yeah. Thank you.
Parna. Thanks, Parna.
Thank you.
Our next speaker will be Dr. Prasanna Kinney. I hereby introduce her. She's a senior consultant anesthesiologist at RG Stone Urology Center in Mulund for the past 12 years. Her area of interest is regional anesthesia and anesthesia for urology cases and laparoscopic cases. She will be presenting a case of lap cholecystectomy in a patient with chronic kidney disease. Welcome, Dr. Prasanna.
Thank you, ma'am. Very good evening to everyone. Am I audible?
Yeah.
Okay. So very good evening. And firstly, I would like to thank the organizers of this webinar for giving me this opportunity to speak about a case which is becoming pretty common. And lap cholecystectomy is something which is posted in almost all centers now, varying from nursing homes right up to the tertiary care centers and corporate hospitals. Although alternative techniques are available for anesthetizing these patients, that is the thoracic segmental spinal with isobaric drugs and other modalities which keep the patient as well as anesthetist peaceful. But there are a few cases where either because of patient refusal or surgeon's choice or other complications, you have to choose GA for these patients. So I hope that by the end of this talk, I will have convinced most of the listeners that giving general anesthesia, a well-balanced general anesthesia in a CKD patient can almost be as safe as using any regional technique. So to begin with, what is chronic kidney disease? It is defined as the presence of kidney damage, either structural or a decreased renal function for at least 3 months, irrespective of the cause. So how can we diagnose this? Mainly, it's the clinical markers. The patient will have albuminuria. There might be electrolyte disturbances, mainly involving potassium because of the underlying acidosis. And some of these patients might present with hematuria. Most importantly, there is raised creatinine levels and decreased GFR or estimated GFR on more than 2 occasions, which are recorded 90 days apart. And finally, we come to the radiological or histological confirmation, where shrunken kidneys are seen either on USG or CT scan, and that confirms your diagnosis of chronic kidney disease. Now, there is a varied etiology when it comes to chronic kidney disease, but what is most common and most important conditions that we face as anesthetists are mainly the hypertension and type 2 diabetes mellitus. So uncontrolled hypertension or long-standing hypertension or type 2 DM can have a higher chance of presenting with CKD. And along with that, sometimes renal vascular stenosis. There might be intrinsic renal diseases like glomerulonephritis, acute kidney injury, which might be secondary to either trauma or severe dehydration, can manifest and progress to chronic renal disease. Interstitial nephritis and nephropathy, they can either be infective like pyelonephritis or very commonly obstructive. So when these obstructive nephropathies are neglected for a longer period of time, they can progress to chronic kidney disease like prostatic hypertrophy or nephrolithiasis. And finally, vesico-ureteric reflux. All other causes are not that commonly seen, but we do have to keep them in mind specifically because we have to work up our patients before giving them general anesthesia for all these. Like in systemic diseases, autoimmune diseases, these patients might be on long-term immunosuppressants or steroids. So we will have to take care of that before administering anesthesia. And in drug-related nephropathy, the long-term use of NSAIDs, chemotherapeutic agents leads to damage. So we have to definitely avoid those. Now, according to the KDIGO classification, I'm just going to be very brief about this. This is mainly for prognosis of how CKD will respond. So as you can see, as the GFR decreases, you have a worse prognosis. And as the albuminuria increases, it causes worse prognosis. So even if your GFR might be mildly to moderately decreased, but if your patient has a severely increased albuminuria, you need to be really, really careful. And also albuminuria will lead to a drop in the serum albumin level. And as you know, most of our anesthetic drugs have high protein binding. So that will need us to be very careful with titration of doses. So coming to the anesthetic considerations in general. So in your anesthetic management starts very much from the pre-operative stage and continues well into the post-operative stage. So in pre-operative evaluation, you have to go for a meticulous history as to how this started, what is the etiology, and how the disease has progressed over how many years or weeks, and the associated comorbidities that are there in the patient. You have to gain insight into the present fluid status. So you can ask them for their present urine output, whether they are on any fluid restriction. And you can also check for signs on the clinical examination. If there is any facial puffiness, pedal edema, ascites, pleural effusion, all these lead to state that the patient has fluid retention. Whether the patient was on renal replacement therapy or hemodialysis, when was the last session done, and how much was the fluid that was removed, all these are important things. Also, these patients are very prone to coagulopathy. So then drug history, whether the patients are on any immunosuppressants or long-term steroids is important. And then you have to have a meticulous clinical examination from head to toe for these patients. In preoperative investigation, you have to do almost all the routine investigations in these patients. So most importantly, you have to check for the renal function test, coagulation studies. CBC gives you an idea whether the patient has any anemia or decreased immunity. LFT was done mainly because the patient is now presenting for a lap cholecystectomy. So LFT is very important there. Chest X-ray, ECG can give you an idea of their fluid status. Any changes in fluid status can again be confirmed by a 2D echo, where you get a fair idea of their ventricular function. Preoperative optimization needs to be discussed in detail with the nephrology team. So the nephrology team has to be in collaboration with the anesthesia team all throughout the preoperative phase, all the way up to the postoperative phase. So optimize these patients well before any elective surgery. And in case of an emergency surgery, anyway, you have to take them up with proper counseling. Intraoperative considerations are mainly to maintain the residual kidney function that these patients might have. So there are only 3 ways to achieve this. First is to maintain the hemodynamic stability. Secondly, avoid nephrotoxic drugs, mainly antibiotics like aminoglycosides, NSAID, chemotherapy agents, anesthetic agents which might lead to nephrotoxicity, and contrast media is absolutely contraindicated. And a strict fluid balance has to be maintained throughout the surgical time, so that these patients don't land into AKI. Now, coming to the specific case that I wanted to discuss. This gentleman was a 46-year-old male with a history of hypertension since 8 years. He was on treatment with a beta blocker and a angiotensin receptor blocker. He was also known case of hypothyroidism on 100 micrograms of thyroxine, but at present he was euthyroid. CKD was present since 2018, but he was not on any RRT at present. He had a history of bilateral open ureterolithotomy in 2018. So this point is very important as it suggests the etiology of the CKD. So probably he was a bit late in approaching the urologist at that time. And so he says that by the time he went for surgery, his creat was already raised and it has remained at a certain level since that time. At present, he came with right hypochondriac pain, gaseous distension of abdomen and heartburn. He was diagnosed on CT to have calculus cholecystitis with the largest stone around 12 millimeter, very close to the neck of the gallbladder, and that's why he was posted for lap cholecystectomy. There was also a history of DJ stenting around 15 days back. It was done preemptively because of the rise in creatinine and the pain in the right hypochondriac region. But even after 15 days, there was no change in creatinine levels. On physical examination, his height was 157 centimeters and weight 64 kg, which gives me an idea that probably there was not much fluid retention in his case. His general condition was good. Pulse rate of 76, BP was normal, and there were no signs of fluid retention, no edema, no pallor as well. Systemic examination did not reveal any significant abnormalities. On airway examination, I did not anticipate any difficulty in intubation. Urine output at present, as given by the history from the patient, was approximately 1 to 1.5 liters, and fluid restriction was kept at 1.5 to 2 liters per day. Now, as you can see, almost all his investigations were within normal limits. So this was a very well optimized patient preoperatively. The hemoglobin was around 16.5, but here again, we need to be careful about such a high hemoglobin because it might not actually give you the true picture. So most of these patients are slightly on the anemic side, but if you see a high hemoglobin, it might be indicating a dehydrated state. So you have to make sure that he is well hydrated before he comes on the OT table. Serum creatinine, right just before surgery was 3.9, and his serum electrolytes were all within normal limits with a potassium of 4.1. His eGFR, that is the estimated GFR, was around 18.36, so it shows severe impairment. RBS was 109. Liver function tests were within normal limits with a normal protein level and serum albumin of 4.41. ECG, chest X-ray, 2D echo, all within normal limits. Thyroid functions, coagulation profile, all were fine. So this was a very well optimized case, and that's why I had no issues taking him up under GA. Now, in preoperative optimization, we first asked him to get a urology opinion as he still had stents, but the urologist preferred to remove the stents as they are foreign bodies and that therefore can serve as a nidus for infection. And these patients are more prone to catching infection. Nephrology opinions, they said he had no need for a pre-op hemodialysis or RRT as his creatinine levels were almost stable for a very long time. So he can be taken up with URIS with raised serum creat. Patient counseling was done regarding the general anesthesia, and also he was explained regarding a need for post-op hemodialysis if needed. Due risk was explained and a valid consent was taken. Beta blocker was continued on the day of surgery, whereas the ARB was discontinued because I did not want to risk any hypotension intraos. Thyronorm was given on the day of surgery, and oral clear fluids were allowed up till 2 hours prior to the surgery. Now, this is very important because if we have prolonged hours of fasting, that itself can contribute to dehydration in such patients. So, as per latest guidelines, you can also use sip till sense, that is around 200 ml of fluid can be given in sips to the patient till they reach the OT. But because he has CKD and I was fearing maybe some amount of delayed gastric emptying, I prefer to keep him NBM 2 hours prior. Intraoperatively, all the monitors that we usually attach, ECG, NIBP, SpO2, EtCO2. I was lucky enough to have an anesthetic gas monitor, so that made my job very peaceful. And we did put in an intra-op Foley's catheter to monitor his hourly urine output. Vascular access, since this was a very short surgery, I just went in for a 20 gauge IV cannula over the dorsum of the right hand. But in case these patients do come for longer surgeries where you have more blood loss or more fluid shift expected, it is better to have a central line in place where you can measure CVP for fluid status. Pre-oxygenation was done, pre-medication given as usual, ondansetron 4 mg, pan, monosep, midazolam 1 mg, fentanyl 100 mg. Lignocard 60 mg IV was given prior to giving propofol. So this helps with analgesia as well as blunting the intubation response. So I did not want to give him too many hemodynamic shifts during induction or intubation. Induction was done with propofol 100 mg in slow titrated boluses. So as mentioned by Dr. Tushar Dedia, if you do an induction slowly with titrated boluses of propofol, it really does not give rise to hypotension as compared to a fast induction. Now, as a relaxant, I use atracurium 40 mg as a loading dose. And since the surgery was over in 30 minutes, so I did not need to give any top-up. Intubation was with a 7.5 ml PVC substitute. Now, before going into the maintenance, we need to keep in mind what the effects of pneumoperitoneum are on these patients. So it can cause a raised systemic vascular pressure, mean arterial pressure, myocardial oxygen requirements, then decreased FRC, VC compliance in the respiratory system. In CNS, it can cause increased intracranial pressure, cerebral blood flow, IOP, catecholamine release, activation of the renin-angiotensin system in endocrine, gastric regurgitation, among others. So if you look at it generally, what you see is that most of these patients might get a hypertensive response because of the pneumoperitoneum. So we have to be very careful. So you have to be prepared beforehand to manage these patients during that period. Maintenance was done by oxygen, air, and sevoflurane. At this point, I would like to say that recent studies have shown, even though it was mentioned earlier that sevoflurane, because of the formation of compound A, causes nephrotoxicity, it has been shown that it is not actually clinically manifesting in human subjects. So sevoflurane has been proved to be relatively safe, but yes, for longer duration surgeries, it would always be preferable to use a more safer inhalational agent like isoflurane. Intra-op analgesia was given by tramadol suppository, paracetamol 1 gram mixed with tramadol 50 mg, which is more popularly called Shivmix, and 0.25% bupivacaine local infiltration anesthesia was given at all port sites. Reversal was done by myopyrrolate, and IV fluid. It has been now proven that RL is much better as an IV fluid compared to NS. especially for shorter surgeries, because NS has the tendency to increase the hypochloremic state, which again aggravates the underlying acidosis. So it would be preferable to use either plasma light or RL, and his intra-op course was smooth with extubation on table. In post-operative analgesia, we used paracetamol plus tramadol mixture again once, 12 hourly. Urine output was monitored hourly and it stayed between 100 to 120 ml per hour. Early destarving was done 2 hours post-surgery with clear fluids, and hydration was maintained to maintain the urine output. Early mobilization, and the patient was discharged on the next day after catheter removal. There was no need for post-operative hemodialysis since the patient's creatinine was again 3.8 in the post-op and his electrolytes were absolutely normal. So the take-home messages from this is that chronic kidney disease affects and has complications in multiple systems. So it is important to take a meticulous history and careful examination, and main aim should be maintaining the residual kidney function without causing any further deterioration as far as possible. You have to exercise caution because of altered pharmacokinetics that can lead to drug accumulation and toxicity. So very, very important to titrate doses as per requirement, keeping hypoproteinemia in mind if that is the case. And fluid balance is difficult to achieve. So careful monitoring for fluid retention, both intra-op and post-op, is very important. Thank you, everybody.
Thank you, Prasanna. I think your presentation has covered up almost all the points. Dr. Vivek Birla, can you give your opinion regarding the same? Hello? Hello? Is Dr. Birla online?
Yeah. Hello.
Yes, sir.
Am I
You're
audible now?
audible. Yes, sir.
Yeah. See, I think she has covered most of the points. Few thing is most important is the patient has to be euvolemic before we take up. Second thing is many times in a practice, clinical practice, what we see na, most of the preoperative investigations are done 4-5 days back, 7 days back, 10 days back. But in such patients, it is good to have a creatinine and electrolyte level in the morning itself of the surgery. That's very vital because they can have drastic changes happening in between also. So don't rely on the test what have been done 4 days back or 5 days back,
Okay.
especially creatinine and electrolyte. And the third thing is for pneumoperitoneum insufflation have to be very guarded because many times the laparoscopic surgeon will tell the anesthetist, "Arey, badao, badao, badao." But you have to be very rigid in that. Ki, no, we cannot increase this beyond this because it is going to have a renal vasculature effect, which will compromise the kidney and increase the creatinine. And lastly, the drug, whatever the anesthetic drugs or anesthetic or antibiotics or your post-op analgesia drugs have to be really taken into consideration because that is the biggest worry which causes rise in creatinine in these patients. So if you take care of this, most of these patients will do well. Thank you.
Okay. Thank you, sir. Now, 2 or 3 questions in the chat box. I think Dr. Churchill Wag has a question. How to confirm adequate hydration in a CKD patient? Ma'am, this is for Dr. Prasanna.
Hydration, basically, the easiest way you can confirm is asking them for their urine output. So that is like a very, very simple and easy way to confirm. If their urine output is good, then there is nothing to worry. But again, I emphasize this that you have to be in touch with a nephrologist as well. The nephrology team has to be involved right from the preoperative stage. And any doubt in your mind that the patient is having fluid retention or if the patient is dehydrated, it is best to consult the nephrologist.
Okay. The second question in the chat box is, does Dexmed have any role in such patients? Do you use it, ma'am?
Yes, we do use Dexmed, but Dexmed has shown the propensity to give extended sedation in CKD patients. So if
Prolonged
it was a
excretion.
long, yes, because of the prolonged excretion. So if it was a longer case which requires extended sedation, which I'm going to shift into the ICU, then probably I would have used dexmedetomidine. But for short cases like lap cholecystectomy, lap appendicectomy, I don't think they need dexmed. Fentanyl can do a very good job.
Okay. One more question is agent of choice to treat hypertension in response to pneumoperitoneum. What will be your choice of agent?
I would go with a beta blocker if the
Okay.
patient is stable and if the heart rate is good. I would definitely prefer a beta blocker. But if you have given a good analgesia and the patient is at adequate depth and your local infiltration anesthesia is given a bit in advance, I have very rarely seen rise in BP during creation of pneumoperitoneum.
Yeah,
But
and
yeah,
one more thing is, ma'am, do you prefer using etomidate as an induction agent?
etomidate definitely would be a better choice because of
Yeah,
its hemodynamic stability, but it's not available everywhere. So
yeah, I agree.
because of that, I go with titrated doses of propofol for a slow induction. Etomidate would definitely be a better choice if it is available.
Just a word, etomidate is a very beautiful induction agent.
Yes.
Fortunately, we work in a place where it is available, and that would be our choice of induction agent.
Yes.
And the hemodynamic stability is beautiful with it. Now, with the advancement in neurosurgery and nephrology, thank you once again, Prasanna ma'am. We will go to our next talk.
Thank you.
It is the latest, in transplant and neurosurgery, the robotic surgeries. The robots are being used for prostatic surgery, then for donor nephrectomies. So our next talk will be by Dr. Amulya Hande. He's a resident in anesthesia at Jupiter Hospital. He will be presenting a case of robotic lap prostatectomy in a patient with ankylosing spondylitis. He will just highlight us how we had induced and managed this patient. Over to Dr. Amulya.
Am I audible?
Yes, you're audible.
Yeah, good evening, everyone. Myself, Dr. Amulya Hande. I am a first year DMP resident at Jupiter Hospital. Yeah. So, today my case presentation is about anesthesia management for laparoscopic robotic prostatectomy in a patient with ankylosing spondylitis. So, these are the aims and objectives of my case. So, before going into the case presentation, so this is a Da Vinci robot which is present in our hospital. So I will share some basic information about this robot. So there are three parts of the robot. It has a surgical console. You can see in the first image. It is a surgical console where the surgeon can sit comfortably and operate. It has a 3D viewer and it has a right and left arm. So the left arm is used to control the third and fourth arm of the robot, and the right arm is used to control the first arm of the robot. And generally in the robot, the second arm is the camera, which is used to visualize the intra-abdominal contents. The second image you can see is the patient cart, which has a four interchangeable robotic arms. So this is my article regarding the robotic assisted laparoscopic radical prostatectomy in a patient with severe kyphoscoliosis and ankylosing spondylitis. So the case scenario was my patient was 65-year-old male with a known case of systemic hypertension, well controlled on regular medication since 10 years, and he was also a known case of ankylosing spondylitis since 25 years. He presented with complaints of sense of incomplete bladder emptying since 3 months and dripping of urine with weak streams since 5 months. So my patient was apparently all right 5 months ago, but then he noticed dripping of urine with weak stream, which was insidious in onset and gradually progressive, and has a sense of incomplete bladder emptying after voiding and persistent urge to pass the urine. He had no history of pain in urination, no history of blood in urine, no history of fever and abdominal pain. He had a past history of systemic hypertension since 10 years. He also has a history of ankylosing spondylitis since 25 years and was on regular physiotherapy. There was no history of bronchial asthma, diabetes mellitus, angina, ischemic heart disease, cerebrovascular accident, thyroid disease, or tuberculosis. He had no history of snoring, breathlessness, and obstructive sleep apnea. He was on a mixed diet. The sleep was disturbed due to awakening at night for voiding. The bowel habits were normal and patient denied of any addictions. He had no drug allergies in the past. He was on tab metoprolol 50 mg once a daily for hypertension. No significant or surgical history or family history. On general examination, my patient was conscious and well oriented time, place, and person. He had a normal build and he was well nourished with no pallar, cyanosis, edema, lymphadenopathy. He was afebrile with temperature of 98.7 degrees Fahrenheit. His pulse rate was 64 beats per minute, regular, normal in volume and character, normal tension, no radial or radiofemoral delay, and all the peripheral pulses were palpable. His blood pressure was 26 by 82 millimeter of mercury, which was taken in left brachial artery in setting position. The respiratory rate was 15 per minute. It was regular and abdominal thoracic breathing, and SpO2 was 99% of room air. His effort tolerance was well. He was a regular swimmer. He was fit for the surgery, and he can comfortably climb 2 flights of stairs. No significant findings were there in the systemic examination. The spine was also examined since he had a history of ankylosing spondylitis since 25 years, but he had normal alignment and curvature of spine, and the spinous process were palpable and normal. Hmm. So there were significant findings in the airway examination. He had a mouth opening of 2.5 finger only, and they were restricted. He had a restricted neck flexion and extension. So what happens in ankylosing spondylitis? There is ossification of the spinal ligament and calcification of the outer fiber of annulus fibrosus of the intervertebral disc. So we get a bamboo spine appearance in this patient. So, due to the fusion of the apophyseal joints and extensive syndesmophytes formation, there is loss of mobility in the cervical and thoracic spine. The cervical spine is most commonly affected in this patient. So, for us, the intubation is challenging in this patient because they had a limited afferent occipital extension. They may have a limited mouth opening if temporomandibular joint was also involved. So in some patients, the TM joint is also involved due to narrowing of the joint spaces. So which can impede the mouth opening, and there can be impedation of transoral approach for the laryngoscope. So he had restricted neck flexion and extension. His dentition was normal. Volumpati classification was grade 3. The thyromental distance was more than 6.5 centimeter, and he had an upper lip bite test of grade 1. So, my summary is 65-year-old male, a known case of systemic hypertension and ankylosing spondylitis, comes under ASA2 with chief complaints of continuous dripping of urination and incomplete bladder irrigation. And on USG abdomen pelvis, there was a large prostatomegaly is a diagnosis, and he was posted for robotic prostatectomy. So in the pre-op investigation, the routine investigations were done. CBC, hemoglobin, WBC, and platelet to rule out anemia, thrombocytopenia, and any infection. Baseline liver function tests and renal function tests were done, which were within normal limits. His coagulation profile was done, prothrombin time and INR. It was also within normal limits. Electrocardiogram and 2D echo was done. So in anesthesia consideration, some patients of ankylosing spondylitis may have cardiac involvement. There can be inflammatory involvement of the heart, which can lead to aortic valve insufficiency. That's why we had asked the 2D echo. The ejection fraction was 60%. No left ventricular regional wall motion abnormality, but there was mild concentric left ventricular hypertrophy. The chest X-ray was normal with clear lung field. Mm, we had also asked for a pulmonary function test, which was also within normal limits. So, in patient of ankylosing spondylitis, there can be fusion of the costovertebral joint, so which can limit the chest expansion, and the patient may also have pulmonary fibrosis. That's why we had asked the pulmonary function test and even ABG to find out whether there is any retention of carbon dioxide. The viral markers were done according to the institute protocol. So, in the expert opinion, we had taken a chest physician opinion for ankylosing spondylitis and fitness for surgery. So, the chest physician had advised, he had given fitness for surgery and advised NEP before surgery. So, these were my preoperative advices. Nil by mouth more than 6 hours for solid food and more than 2 hours for clear liquid. So, nebulization was given with duoline and Budecort prior shifting to OT. He was on tablet metoprolol, which was asked to continue on the day of surgery with sips of water. Post-operative intensive care unit was explained. Since we are anticipating that it was a difficult airway, so we had explained the relatives and the patient about the awake fiber optic intubation. Adequate blood products were reserved, and the patient was taken for surgery under ASA2 with de-risk. So our plan of anesthesia was general anesthesia with endotracheal intubation using a video laryngoscope. Since there was a restriction in neck extension and flexation, we had kept the difficult airway cart ready, and also fiber optic intubation cart was kept standby. So after taking informed consent, the patient was shifted to OT. Before shifting the patient to OT, all the anesthesia machine checklist was done. So according to the American Society of Anesthesiologists, the standard monitoring were attached: electrocardiogram, pulse oximetry, non-invasive blood pressure, capnography, temperature monitoring, entropy monitoring, respiratory gas monitoring, and we had taken two large bore IV lines with good extension of around 100 centimeter each, because before starting the surgery, while doing positioning, both the hands are getting tucked inside. So in the robotic surgery, we have less access towards the patient hand. So it is very important to take large extension to improve accessibility for giving any drugs. So the patient was induced with general anesthesia. After doing pre-oxygenation for 3 minutes, the patient was induced with general anesthesia using induction agent, intravenous fentanyl around 1 to 2 miles per kg, intravenous propofol 1.5 to 2 milligram per kg. Since we are suspecting that it would be a difficult intubation, we had used intravenous succinyl choline with dose around 1 milligram per kg. And after that, the relaxation was maintained with intravenous citracurium or 0.5 to 1 milligram per kg. So we had intubated the patient with number 8 flexometallic tube using a video laryngoscope with the assistance of bougie. And we had kept difficult airway card and fiber optic intubation card standby. So after confirming the ETCO2 and air entry by auscultation, the ventilatory parameters were set. So positioning in the robotic surgery is very important in anesthesia point of view, because the position is lithotomy position with a steep head lobe, with a steep Trendelenburg, which is around 30 to 40 degrees. And we had secured a nasogastric tube to reduce the gastric pressure and to prevent any gastric secretion flowing into the eye due to the steep Trendelenburg position. Adequate eye padding was done to prevent ocular injuries. The arms were tucked by the side and warming sheets and warming blanket was applied. The compression stocking were applied to reduce the risk of DVT. So when the pneumoperitoneum was created, before the docking of the robot, there is increase in intra-abdominal pressure. So we had managed the ventilatory setting. We shifted the ventilatory setting from volume control to pressure control ventilation. We added a peak of around 4 to 5, and we increased the duration of inhalation to promote gaseous exchange. So after urethra is categorized, the patient was carefully positioned and the robot was wheeled between the legs. To prevent the patient sliding from the OT table due to the steep pendulum bug, positioning devices and non-slipping pads and cross-body taping was done. The shoulder supports were kept laterally at the acromioclavicular joint to prevent the brachioplexus injury. The position of the tracheal tube was checked regularly. So due to the steep Trendelenburg position and due to the pneumoperitoneum, there can be caudal shift of the diaphragm. So due to which there can be accidental endobronchial intubation. So we have to check the position of the tracheal tube regularly within certain interval of time. So these are the images showing the steep Trendelenburg position and the adequate padding, compression stocking to prevent bony erosion and nerve injuries. So the maintenance of anesthesia. So we had used inhalation agent sevoflurane and air with oxygen in 1:1 ratio, and the minimum alveolar concentration was maintained at 0.8. Using of the neuromuscular blockade during maintenance of anesthesia is very important because we need to paralyze the patient until the robot was undocked till the end of the procedure. If the patient bucks, there can be chances of intra-abdominal organ injury. So the periodic administration of non-depolarizing muscle relaxant was given to prevent the patient movement. Usually we had used cisatracuronium with 2 mg top-up every 35 to 40 minutes. In the fluid management, we had used a hotline to deliver the warm fluid since it was a long duration surgery and to prevent hypothermia. The patient was given Renal acted as a maintenance fluid intraoperatively. But till the anastomosis were done, the fluids were given sparingly. The fluids were restricted to reduce the urine production. In the pain management part, we had given good analgesia. We had given intravenous paracetamol 1 gram, intravenous tramadol. The non-steroidal anti-inflammatory drugs were avoided. And before extubation, we had given a transverse abdominis pain block under USG guidance. So under all aseptic precaution, we use 0.25% bupivacaine 40 cc with 8 milligram of dexamethasone. The drug was infiltrated in the plane between inferior oblique and transverse abdominis after negative aspiration of blood. So following anastomosis and undocking and removing the robotic parts, and after reversing the bed at supine position, the patient was extubated by giving reversal myopyrrolate, and the patient was extubated with adequate suctioning after complete return of muscle power and tone as per the extubation criteria. And post-operatively, the patient was shifted to the intensive care unit for observation. So my take-home points for the robotic prostatectomy are, so there is a spatial restriction due to large robot around the patient's side. So, and it is a long surgery. So we need to give warm fluids to prevent hypothermia. We need to have good IV access with long extension. Securing pressure points and bony prominences are very important because the position is steep Trendelenburg. Airway edema is one of the concerns post-operatively or laryngeal edema. So we need to check we can perform the test, the cuff leak test to check whether any laryngeal edema is there. The practice drill should be done for efficient docking and undocking of the robot. Multimodal analgesia is very important and adequate relaxation intraoperatively to prevent any intra-abdominal injuries are very important. Yeah. Thank you.
Thank you, Dr. Amartya. I think you have covered up almost all the points. I will give one or two insights later, but now I want Dr. Vivek Birla for his input in the case.
Hello.
Yes.
Yeah, I'm audible, I suppose.
Yes, sir.
See, 2-3 points. I suppose this was a radical prostatectomy for cancer prostate. If I'm
Yes, sir.
not wrong.
Yes.
Yeah. Because it was never mentioned in anywhere in the case.
Yeah, they had sent the frozen section, sir. for the prostate, and then, they went ahead.
No, but ideally speaking, we are supposed to be doing a prostate biopsy pre-operatively. You don't pick up and
So
do
they
frozen
had
section.
done, but it was not informative. So once again, they repeated intraoperatively.
Surprising. This is something unheard of. Anyway, ankylosing spondylitis is a very special challenge in any surgery, especially if the patient has a severe kyphoscoliosis. And many of these patients would have a severe kyphoscoliosis that makes surgical induction, anesthetic induction, intubation, everything very difficult, including the surgical positioning. So that is a very, very critical part when the person has a severe kyphoscoliosis associated with ankylosing spondylitis. That's one thing. Here, probably he did not have such a bad thing, except the cervical spine, which was involved more.
Yes,
Second thing is, when we are doing nowadays we have started doing a PSMA scan for a cancer prostate patients. Okay. But now, a few years back, we were relying on a bone scan for diagnosing whether patient has a bony metastasis in a cancer prostate proven patient by a preoperatively prostate biopsy, which is done transrectally via prostate biopsy guns. Now, in ankylosing spondylitis patients, also you would have a bone scan positivity, and in a CA prostate also you may have a bone scan positivity. So it is very difficult to separate out bone metastasis because of CA prostate, or it is ankylosing spondylitis without any metastasis, when we were relying on a bone scan per se. Nowadays, luckily, we have a PSMA scan. So PSMA scan would be positive, then we know that is a prostatic metastasis. If PSMA scan is negative, then probably we know it is a ankylosing spondylitis changes and not related to CA prostate. So this was the point which is very vital clinically. That's what I thought I would speak about it. So it is only these 2 points I would like to highlight. Thank you.
Okay, sir. Thank you. Thank you for your insight. Now, 1 or 2 points that I would like to insist. In a robotic case, the anesthesia consideration, although the surgery is skillful, but the anesthesia part is extremely important. You have to evaluate the patient from the pulmonary function point of view, the steep head low, the pressure point coverage. The hypothermia is, noted because the robotic OT is at a temperature of 16 to 18 degrees Celsius. So using warm fluid warmers are extremely important, and the anesthetist and the anesthesia machine is kept at quite a distance. So once the patient is induced, the next 4 hours is the stress. You have to take care of the patient. So please be extremely meticulous in your planning of anesthesia for a robotic case. That's what I would like to insist upon. Now, we have our last talk. Our last talk is with Dr. Aniket Hase. Well, all the patients, the CKD patient, the patient on dialysis, patient post-renal transplant, it is the nephrologist and the urosurgeon together as a team who gives us insight into the case and how they optimize the patient and hand over to the anesthetist. Dr. Aniket Hase is a consultant nephrologist and a transplant physician at Jupiter Hospital. He's a teaching faculty for DNB nephro students, and his area of interest is transplant and critical care nephrology along with dialysis patients. I hereby welcome Dr. Aniket Hase. Hello.
Hello. Yeah. Thank you, ma'am.
Yeah.
I'll just share my screen.
Yeah.
I think the previous screen needs to be unshared first. Is my screen seen?
Yes, it's seen well.
Okay. So thank you, Dr. Sneha, for that kind introduction. And we are blessed to have our expert and very competent anesthesia team at Jupiter Hospital to manage our transplant and CKD patients. So thank you, organizers, also to giving me this opportunity to interact on this important topic of perioperative management of chronic kidney disease patients. So in next 20 minutes, I'll be covering the topic under the following points. 100 years ago, a renal physiologist, Mr. Homer Smith, very aptly described the importance of normal renal function. What he says is that bones can break, muscles can atrophy, glands can loaf, even the brain can go to sleep without immediately endangering our survival. But when the kidney fails, neither bone, nor muscle, nor gland, nor brain can carry out their functions. He also goes on saying that it is no exaggeration to say that what the composition of the blood is not determined by what we take by mouth, but what the kidney keeps in. So if the kidney is normal, there is no worry, as it can correct and compensate the internal environment by adapting and adjusting. So what are the functions of the kidney? So kidney has excretory function. Kidney excretes metabolic nitrogenous waste products, excess of water, phosphates, drug metabolites. Impairment of this excretory function may lead to accumulation of nitrogenous waste products like BUN creatinine, which is called as azotemia. And when it is accompanied by organ dysfunctional symptoms, it is called as uremia or uremic symptoms. Then accumulation of drug metabolites due to impaired renally excreted drugs leads to drug toxicities. Another important function is regulatory function. So kidney regulates water balance, sodium balance, acid-base balance, potassium balance, and blood pressure via RAS system. An impairment of these regulatory functions can lead to water retention, fluid overload, hyponatremia, hyperkalemia, acidosis, and hypertension. And another most important under-recognized function is the synthetic function. That is synthesis of erythropoietin, which maintains the erythropoiesis. And impairment of kidney function can lead to anemia. Renin secretion, which helps to maintain the BP and renal autoregulation. And 1,25-hydroxy, that is activated vitamin D, is produced in the kidney, and along with calcium and phosphorus and PTH, it maintains the bone health. So if kidney is not able to maintain these functions, it is called as kidney failure, and it's threat to internal environment, and hence high risk for surgery. Now this kidney failure is of two types. So one that occurs in days to weeks is called as acute kidney injury. It is defined as increase in creatinine of more than 0.3 milligram per deciliter within 48 hours, or increase in creatinine by more than 1.5 times the baseline before the previous baseline over the last 7 days, or the urine output criteria, which is urine volume less than 0.5 ml per kg per hour for 6 hours. And acute kidney injury is staged as stage 1, stage 2, stage 3 as per the severity according to KDIGO criteria. And if this loss of function occurs for over months, then it is defined as a chronic kidney disease. That is abnormalities of kidney function or structure for more than 3 months with implications to health. Now, CKD is classified as per GFR and albuminuria categories into 5 stages, and the patient progress to end-stage renal disease requiring kidney replacement therapy in form of dialysis and transplant. Now, CKD is becoming a major public health problem. As per 2017 data, 850 million people are living with some form of kidney disease, which is twice as much as diabetics, 20 times as much as cancer prevalence, and 20 times as much as patients living with HIV or AIDS. And it is emerging as the leading cause of death. By 2040, it is expected to be the 5th leading cause of death. Diabetes is the most common etiology of chronic kidney disease currently, and aging population is increasing. Therefore, the number of patients living with CKD is increasing, and hence number of patients with CKD requiring surgery also increasing. So patients with CKD or end-stage kidney disease undergo procedures like kidney transplant, biopsy, access creation. They also require other routine surgeries like the cardiac surgeries, orthopedic surgeries, intra-abdominal surgeries, neurosurgeries, and the procedures like cataract and dental procedure. So why to worry? So it has been seen that in orthopedic surgery, pre-op increase in creatinine by 2 times increases the mortality by 4 times. Similarly, in cardiac surgery, mortality was 15 times more in CKD patients as compared to non-CKD patients. And this is a systematic review and meta-analysis of CKD patients and post-op mortality published way back in 2008. In various surgeries, it can be seen that mortality was more in patients with the chronic kidney disease as compared to non-CKD patients. So why the surgeries are high risk? So that is because the perioperative management is complex and challenging. In CKD patients, due to azotemia and uremia, there is risk of bleed, delayed wound healing, hyperkalemia, risk of hyperkalemia which leads to arrhythmias, metabolic acidosis, And associated comorbidities like diabetes, hypertension, ischemic heart disease confer additional cardiovascular risk. There are altered drug clearances predisposing to toxicities. Period of blood pressure control is a challenge. Vascular access preservation. Many of the times the AV fistulas which are there conk off during the major surgeries. As a result, CKD patients are a high risk for complication and have prolonged ICU stay. So what is the answer to this? It is a perfect perioperative evaluation for perfect perioperative outcome. So how do we do it? So a careful history has to be elicited with an aim to assess the kidney disease and determine the underlying cause of the kidney disease. Also to determine the associated complications with the AKI or CKD like uremia, electrolyte imbalances, disturbances, anemia, hyperkalemia, fluid status assessment, and if patient needs dialysis or not. As then Dr. Prasanna described, the assessment of residual renal function is also very important in CKD patients who are not on dialysis or even on the dialysis. Associated comorbidities like diabetic, what drugs is patient on for the diabetic, glycemic, how is the glycemic controls? Then any thyroid illness, also drugs like ACE inhibitors, ARBs, SGLT2 inhibitors, which can impair renal function periop, needs to be noted. Another important history is of lower urinary tract symptoms. If any cystopathy, obstructive uropathy is there, if any ongoing UTI is there, or asymptomatic bacteria which needs attention, or need of catheterization, and possibility that patient may go into urinary retention post-op, risk has to be determined previously. A careful physical examination is required and it is necessary to assess blood pressure, whether patient is hypertensive, hypotensive at the baseline, so that the organ perfusion can be maintained periop. Volume assessment, whether the patient is hypovolemic. Volume assessment can be very tricky, whether patient is hypovolemic, hypervolemic, or euvolemic, and then decide upon maintenance fluid or IV fluids or diuretic or dialysis accordingly. Nutritional status is also important, as in periop, surgical outcomes and wound healing depend on that. It also tells about the body reserves to withstand the procedures. Then the lab evaluation has to be looked at critically. So in lab evaluation, we see complete CBC, that is hemoglobin. The target hemoglobin as per the guidelines, KDIGO guidelines for any CKD or patient on dialysis is 10 to 11.5. If it is an elective surgery, the hemoglobin should be built up with replacing the iron stores and erythropoiesis stimulating agent like erythropoietin. In case of emergencies, packed cell need to be transfused. Total leukocyte count has to be seen, whether patient is eosinophilia, which should be treated. Urine routine has to be seen for presence of UTI or asymptomatic bacteremia. A cardiac risk assessment should be done for the cardiac risk. Patients are at high risk of bleeding, hence, and due to platelet dysfunction, hence assessment of platelets. Usually bleeding time is not well standardized, hence platelet function has to be assessed by PF100. Coagulation, PT, PTT assessment. And if patient is high risk for bleed, ideally should undergo a thromboelastography and supplement the components accordingly. Now, after examination and laboratory evaluation, it is important to assess the surgical risk as to how do we quantify this risk. It is helpful it is helpful that we have the calculators which have been developed over the years. With this, we can determine the risk of acute kidney injury, risk of need of kidney replacement therapy, and progression of CKD. And these have been well validated in various populations. So these are some of the calculators which are available online in an application. So this one you can see is a dialysis risk after cardiovascular surgery. This is the score by Mehta and al. And this is a Cleveland Clinic score. So we can see that objectively we can determine the risk, estimated risk for dialysis, and accordingly we can counsel the patient and the relatives. And one point to note here is emergency surgery is always associated with 5 times greater the risk of death. So preoperative, optimize the fluid status. If patient is hypovolemic, give IV fluids and make him euvolemic. If patient is hypervolemic, use diuretics or assess the need for dialysis. If patient is euvolemic, give maintenance fluid. Potassium, target potassium below 5, target sodium more than 130. Patient should assess for acidosis. If acidosis is there, it should be treated. Bicarbonate should be more than 22. Creatinine should be less than 7 or 5. Studies have shown that uremic platelet dysfunction start at creatinine of 5 and is significant at creatinine above 7. This is the reason why these figures are there. And patient's BP should be at target and hemoglobin at target, as we have discussed, between 10 to 11.5. Now, preoperative dialysis. If patient is already on hemodialysis, patient has to be dialyzed well before the surgery. We have to assess whether patient is adequately dialyzed. If not, we have to dialyze him adequately and control the uremic milieu. A patient is ideally to be dialyzed a day prior to the surgery. Avoid any anticoagulation during dialysis. Ultrafiltrate to the dry weight so that patient is kept euvolumic, and post dialysis after 4 to 8 hours, check electrolytes, creatinine, PT, PTT, and CBC on the day of surgery. If patient is a chronic kidney disease not on dialysis, if patient is euvolemic, there are no uremic symptoms, hemodynamically stable, potassium is less than 5, sodium is more than 130, BUN is less than 70, and creatinine is less than 7, then there is no need of dialysis. Preoperative drug consideration, it is very important to note the drugs which patient is already on. For example, the antihypertensives, ACE, ARBs, beta blockers. So we need to stop the ACE, ARBs before any major surgeries, because these can lead to impaired renal autoregulation and impaired renal perfusion and aggravate the acute kidney injury. Similarly, beta blockers need to be continued as they can cause rebound hypertension. Calcium channel blocker, clonidine, may be given as per the BP, but usually we avoid it. So because our anesthesia is hypotensive, that's why it is better to maintain a better map when the patient is wheeling into OT. Similarly, SGLT2 inhibitors has to be stopped because they can cause euglycemic ketosis, also impaired renal autoregulation. Diuretics, depending on the volume status, have to be continued or discontinued. Antiplatelet usually are stopped, but as per the surgeon and the procedures, aspirin can be continued. Antibiotics, loading dose of the antibiotics remain the same. Further doses have to be modified as per the renal function. And certain nephrotoxic antibiotics like vancomycin, ammonoclidase have to be largely avoided. And it is very important to mention that if the patient is on dialysis, we have to take care of the access, especially the catheters or the AV fistulas. The AV fistula has to be marked that this hand is of AV fistula, no BP measurements on that, no prick on that, no tight dressing, and the access, because access is a lifeline of dialysis patients. And if the patient is not on dialysis, it will be good to preserve a non-dominant hang without any pricks, so that in future it can be used, the veins can be preserved for AV fistula creation. Now, uremic bleed. Uremic bleed needs a special mention. So as the uremic milieu is responsible for platelet dysfunction and hence the bleed, and hence the patient has to be dialyzed well before and optimized before the surgery. Now, target creatinine should be below 5 to 7. So as we have discussed, the uremic dysfunction of the platelet dysfunction start above the creatinine of 5 and is significant above the creatinine of 7. So it is desirable to have creatinine below 5. Raise the hemoglobin, maintain the hemoglobin at the targets. If still patient is at high risk of bleed, we can give desmopressin either intranasally, IV, or subcutaneously. This improves the platelet function. But the word of caution while using desmopressin is we have to see the serum sodium. It can cause acute hyponatremia if sodium is already low. So usually we prefer desmopressin only when the sodium is above 132 to 135. And if in case the patient bleeds, then the rescue with the FFP or this platelet transfusion or factor 7 has to be kept in reserve. Intraoperatively, fluid resuscitation is typically with either crystalloids or colloids. The idea of crystalloids and colloids is always debatable, and there are a lot of text, but the recommended choice of IV fluid in kidney patient is now normal saline. However, we have to be careful if the volumes are too large, of more than 30 ml per kg, it can lead to hyperchloremic metabolic acidosis and exacerbate the hyperkalemia. Hence, in that case, to maintain euvolemia, we should use balanced solutions if large volumes are needed. Volume overload increases the mortality and it is associated with adverse event. Hence, we have to see that patient does not go into volume overload. It can cause to adverse event like ileus, pulmonary edema, prolonged hospitalization. And the aim of maintaining the mean arterial pressure above 65 to 70 or higher if the patient has uncontrolled hypertension previously, because then the kidneys and organs will be used to the higher perfusion pressure. So maintaining the mean arterial pressure is the most important key for preservation of renal function. Target the maintenance of urine output to more than 0.5 ml per kg per hour. And anesthetic team monitor well with CVP, pulmonary artery wedge pressure, or intraoperative transesophageal echoes, or newer monitors which monitor stroke volumes and assess the cardiac preloads are now available. Special mention at laparoscopic surgery with intra-abdominal pneumoperitoneum is a common technique favored in non-invasive nature and faster wound healing and reduction in perioperative pain. But however, this laparoscopy can be associated with reduction in renal perfusion. Hence, to preserve renal blood flow, abdominal insufflation for pressure should be less than 15. Laparoscopy can cause hypotension, which will further aggravate the kidney injury and decrease renal perfusion. Hence, to mitigate these changes, adequate fluid replacement is recommended. Also, some procedures may require iodinated contrast, and the ideal strategy to prevent contrast nephropathy is to hydrate well, avoidance of other concomitant nephrotoxic agents, prevent hypotension, and possible use of adjuvants like sodium bicarbonate and acetylcysteine. Post-operatively is the most crucial period for identifying the kidney injury or worsening of renal function. So there should be strict input-output charting. Urine output should be charted every hourly. Once patient is mobilized and possible, daily weight should be taken. Daily renal chemistry and electrolyte should be done. Nutrition preferably should be started. Enteral nutrition is preferred to start early. Drug dose adjustments as per the renal functions. Pain management. Avoid non-steroidal anti-inflammatory drugs, long-acting opioids, or gabapentin. Because of the impaired renal clearance, the side effects of these medicines will be increased. IV fluid management will be discussing further. So this is on pain management. So management of pain is a very important aspect. So it is advisable to avoid NSAIDs as they decrease the prostaglandin levels and increase renal vasoconstriction, and therefore decrease the renal perfusion. They cause salt water retention. Therefore, prefer paracetamol or tramadol for pain relief. In amongst opioids, fentanyl is safe. Avoid morphine and codeine. Now coming to fluid management, determining fluid status is a very challenging. So clinically, it can be determined by edema, Krebs, oxygenation, and objectively with help of 2D echo, IVC, LVDPs, or by ultrasound with IVCs and lung comets. So this was the LUST trial, which showed the sensitivity of auscultation was only 9%, while the dose of pedal edema was 3%. While those patients who had moderate to severe congestion on ultrasound, 61% of didn't have any crackles, and 80% did have any peripheral edema. Thus, the classical physical signs like lung auscultation and peripheral edema poorly reflect the interstitial lung edema, and hence ultrasound should be used for fluid assessments more reliably. So, lung ultrasound as compared to conventional X-ray and NT-proBNP and conventional this thing has better sensitivity and early diagnosis. And it is becoming essential for anesthetics and intensivists and nephrologists to learn this bedside ultrasound assessment by fluid status assessment by ultrasound, bedside ultrasound. Another technique for more accurate fluid assessment is bioimpedance. Studies comparing bioimpedance with clinical assessment and USG has shown to be better and more sensitive and specific. So to summarize, if patient is euvolemic, continue maintenance fluid, normal saline or balanced solution if large volumes are needed. Hypovolemic, if patient is hypovolemic, hydrate well with balanced solution, prevent hyperchloremic acidosis with salines. If patient is hypervolemic, restrict the fluids, give diuretics or dialysis if required, and because with each kg rise in fluid increases the mortality. So we will see a couple of cases. So this was a call. These are all the cases for which we had calls. So this was a gynec case from the gynec department. This was a gynec surgery, laparoscopic hysterectomy, day 2. Patient was referred for raised creatinine. Patient had convulsion, edema, and breathlessness. On examination, patient was drowsy post-ictally. There was significant edema and had a nasal Krebs. And the lab showed that creatinine was 4 milligram per deciliter, sodium was 116, she had hyponatremia, potassium was 5, chloride was 89. HB was 8 and calcium was 8.5. Ionized calcium was in normal range. Pre-op labs, creatinine was 1.5, sodium was 129, potassium was 4, chloride was 101, and hemoglobin was 11. So if we see, patient has hyponatremia. Now this was pre-op potassium, sodium was 129, which was already on the lower side, and probably patient had received hypotonic fluids post-op, and that led to acute hyponatremia within the 48 hours, leading to convulsion. So it is very important to check the electrolytes post-op and avoid hypotonic fluid if already the sodium is on the lower side. Second, patient had AKI. Already, if we see the creatinine was 1.5, which was just above at the higher normal limit. So patient was probably dehydrated pre-op, and post-op she received NSAID. So this again was an NSAIDs induced acute kidney injury.
को म्यूट कर दे
And
तो तीन है तीनों को ना
and
थोड़ी
anemia.
से मुड़वाने नीचे से
So anemia was probably
बढ़ेंगे।
because of the blood loss and
ठीक दिखता
dilution.
देख ओके
Going to the next case.
ले पा
This was a call for a raised
हाँ।
creatinine and metabolic acidosis. So patient was diabetic hypertensive, had ischemic heart disease with EF of 45%, was on SGLT2 inhibitors and ARBs, underwent laparoscopic appendectomy, and we got a call on POD2. It was a fair pain control on examination. Patient was dry, dehydrated. Creatine was 2.2, sodium was 138, potassium was 5.6, hemoglobin was 10, pH was 7.22 with bicarb of 13. There was a metabolic acidosis with anion gap of 22, which was high anion gap. The serum ketones were positive and sugars were 115. So it was a euglycemic ketosis. Pre-op creatine was normal. Potassium was already on a higher normal side. So if we analyze it, it was an acute kidney injury, probably secondary to SGLT2 inhibitors like dapagliflozin and ARBs, which impaired the renal autoregulation and prevent and impaired the renal perfusion. Second, there is a high anion gap metabolic acidosis, which was probably because of euglycemic ketosis because of the SGLT2 inhibitors. Now, SGLT2 inhibitors cause euglycemic ketosis by mechanism of the mechanism is by glucose loss, and therefore there is decreased insulin. There's a patients on NBM, there's carbohydrate deficient diet, so there is increase in glucagon. So this altered ratio leads to lipolysis and ketogenesis. This is how it causes euglycemic ketosis. Then the hyperkalemia. Already the potassium was at a borderline high, and this ARBs which were continued probably had led to hyperkalemia. Hence, preoperatively, stopping SGLT2 and ARB 48 hours before the surgery is important to prevent these complications. So moving on to case 3. So this was a call received for raised creatinine. Patient was a 65-year-old male, diabetic hypertensive, had a past CVA, had retinopathy, chronic kidney disease with baseline of 2.5 to 3. He had an acute coronary syndrome. He underwent angiography. There was a triple vessel disease or plan for CABG. So on examining, patient had edema, orthopnea, dyspnea, had on minimal exertion, bilateral edema up to the knee was there. He had creps. Or 2D echo showed congested IVC, lung comments, raised LVTP. He was on maximal dose of diuretics, furosemide of 40 TDS and metalazone of 5 mg BD. And still his urine output maximum was 1.5 to 1.6 liters. And these were his labs. Creatinine, the baseline 3.2 had increased to peak of 6, and it was on reducing trend, which had come up to 5. Sodium was 128, potassium was 4, and hemoglobin was 9. He was anemic. So the problem was, the aim was that suboptimal response to diuretics. He was in volume overload. There was acute on CKD. However, it was recovering as peak creat was 6 and it was coming down. He had anemia, hyponatremia. There was no metabolic acidosis or no hyperkalemia. So this patient was dialyzed for making him euvolumic for optimization of fluid. Hyponatremia automatically got corrected as probably it was dilution. After 2 sessions of hemodialysis, we removed around 3 to 3.5 liters of fluid, and patient was euvolumic. Anemia also improved without getting blood transfusion, again suggesting that probably it was dilutional. And before going to the OT, on the day of surgery, creatine was 2.5, sodium was 136, and patient was euvolumic. Result was it was a successful outcome. Patient did well post-op. There was no dialysis requirement post-op, and the serum creatinine settled to 2.8 milligram per deciliter. Hence, it is important to optimize the fluid status. And if the patient has chronic kidney disease and suboptimal response to diuretic, decision has to be taken to dialyze and optimize before surgery. The last case is this was a 28-year-old girl. She was a CKD5 on maintenance hemodialysis. She was suffering from a Bernard-Sodier syndrome. This is a congenital platelet disorder in which the platelets are dysfunctional and they are prone to bleeding. And she was diagnosed with pulmonary tuberculosis a few months back, and later she had a spine tuberculosis, and then she was planned for a decompression surgery and fixation. And so this was a great challenge because she was on a congenital platelet bleeding disorder. She was also on long-term steroids for her glomerulonephritis because her native disease was glomerulonephritis, and now she was on replacement dose of the steroids. Though she was on maintenance hemodialysis, her creatinine was 11, potassium was 6.2, hemoglobin was 8, platelets were 15,000. So in consultation with the hematologist, the surgeon, and the anesthetic, had a meeting and discussed the case, and we optimized each and every aspect. Hemodialysis was done, for 3 successive days. The creatinine was brought down to below 5, potassium was brought down to below 5. Anemia, she received a blood transfusion, and her hemoglobin was optimized to 10. And as a protocol for the bleeding disorder, she had to be given antifibrinolytics, desmopressin, pre-op, platelet transfusions to be given to get the platelets above 50,000 and then go into operation, keeping the FFP's cryos ready. And if the patient has a severe bleeding, then factor 7A should be available. So this patient had an intra severe bleeding. She required FFP cryo and she was given factor 7A. And it was a successful outcome. Post-op bleeding was, post-op dialysis was continued regularly and patient had a successful outcome. So the key message is patient requires good preparation, good history taking, assessment, drugs which are going to be assessed, volume status has to be assessed, lab has to be assessed, and the key is maintaining renal perfusion and multidisciplinary approach. Thank you.
Thank you, Aniket. I think that was a very, very important and informative talk. And now I can really thank you that with Aniket being the consultant nephrologist in the pre-op, you all can understand how the patient is optimized and the decision whether to wait for 1 or 2 days or, we can optimize the patient and then take up for a better post-op outcome. And the cases which you have discussed have really, that low platelet case was very challenging, but yes, it was a very much team approach. And the the gynec patient, they were really, team approach me, that patient, all have been doing well. Thank you, Aniket, for your informative talk.
Thank you.
Yeah. Manisha and Parna, any inputs for the case? Hello?
Yeah. Thank you, Dr. Aniket. It was an excellent presentation. And
Thank you.
regarding the robotic case, I would like to say that in ankylosing spondylitis patient, as it is, positioning is very, very challenging. So the best thing pre-operatively to do is, as you take the patient on the table, you ask the patient to position himself the way he is comfortable, because we need lithotomy for robotic, and that itself could be very challenging because the hip is also fused. So, and also there is flexion of the cervical spine. So slightest of, problem or slightest of jerky movements during the positioning also can lead to fractures in these patients. So that's why best thing is to make them position themselves after shifting on the table, and then accordingly after giving GA you can give the position like pre-op.
Yes, I completely agree with you, Parna.
Yeah. And regarding etomidate, I wanted to ask that whether you prefer that for as induction agent for all the patients or just with a compromised cardiac function?
More for patients with poor cardiac function,
Sure.
but
Okay.
my lab prostatectomy was a very fit patient. He was a swimmer actually.
Okay.
Except for
Yeah.
that, and that was my first robotic case.
Okay.
So Angstbong was the only challenge in this patient, and yes, we had kept the FOB standby, but with VLC, if you see we could not see the cords directly on the screen. We had to manipulate so as to see. I could see just the posterior ching, and with great efforts, we could pass the bougie.
Yeah.
So it was this thing from the intubation point of view, it was challenging, and all the challenges that we face in a robotic case.
Yeah.
You really have to be careful with the head low position, otherwise periorbital edema, everything, all you all can see.
Absolutely. Yeah.
And thank you, Dr. Aniket, once again for an excellent talk. Thank you.
Thank you.
Yeah, with that, I think we come to the end of the session. Thank you all. Thank you.
Thank you, Sneha. Very well moderated. An excellent presentation. I think there are lots of take-home messages from this webinar today.
Okay. Thank you all.
Dr. Parna, you will do the vote of thanks?
Nilima.
Yeah,
And
yeah, okay.
yeah, Dr. Nilima. Yes.
Yeah, yeah. What wonderful webinar, really wonderful webinar. Thank you, Thane ISA, for this wonderful webinar. Thank you, SAM's office bearers. Thank you, Dr. Vivek Birla, sir, chairman for today's webinar. Sir's comments were very practical and valuable. Thank you all the speakers, Dr. Tushar Dedia, Dr. Prasanna Kini, Dr. Amulya, and Dr. Aniket Hase. Very well presented by all four speakers. Thank you so much, Dr. Sneha Vaswani, for conducting this webinar so smoothly. Thank you, Mr. Ganesh from Geneca Technologies for this online platform and all the technical support. Thank you, MMC Observer, Dr. Rochna Bakshi, and thank you all the delegates for the overwhelming response. It really gives us encouragement to carry out such webinars time and again. Thank you so much. Manisha?
Yeah, thank you, Nilima. Thanks for everything. I think we are done.
Yeah. Okay, Dr. Katkade wants to, Katkade sir wants to have any comments?
No, thank you very much. Excellent presentation. And actually, regarding Ethomidate, nowadays we do I have been doing lots of neurosurgery cases. So in these patients also, they have got a very labile hypertension, bradycardia, hypotension. So I find Ethomidate to be a more cardio-stable as far as induction is concerned. So it's a very good anesthetic agent to be keep available in the places. It's a very good thing. Otherwise, everything was superb. And for robotic surgery, particularly the radical prostatectomy, hypothermia is a big concern. Patient, they do get hypothermia. And I like Dr. Parna's suggestion that even if we have some obese patient coming for spine surgery or something, we used to give preoperative trial positioning of the patient. If you ask a patient to lie in a prone position or lateral position, whatever it is, so you are really accustomed and habituated. Like you do a trial laryngoscopy before induction. If you do a trial positioning before induction of anesthesia, you are well versed, because putting the lithotomy rods in a proper position, in a proper angle, that matters a lot. We have to be very, very careful about the nerves and ligaments. So it's a very good thing, very nice. Thank you very much. Thank you. Congratulations, Dr. Manisha, Dr. Parana, Dr. Nilima and team, Dr. Sneha, Dr. Vivek. Thank you very much. Thank you, everybody. Dr. Hase sir was very, very informative. And I congratulate Dr. Prasanna Kini. She is the youngest of the lot and she has done an excellent presentation. Congratulations, Dr. Prasanna.
Thank you so much, sir.
Thank you.
Actually, Prasanna is my daughter's classmate, Kashmira's classmate. We are very close friends. Okay, chalo. Congratulations. Keep it up. Please keep it up. All the best. Thank you. Bye.
Thank you. Thank you, sir.
sir.
Thank you,
Thank you.
everybody.
Good night.
Thank you.